Our first speaker is Arthur Colbert. Dr. Colbert he's our friend, and so we call him Arthur, and I didn't know all these wonderful things about him, and so I'm going to just share a few of those with you. He's currently the senior advisor for the Missouri Foundation for Health in health literacy, and he's overseeing the development of our statewide health literacy program and enhancement center. Prior to this, Dr. Colbert spent 31 years as a faculty member and dean at Boston University, but then, of course, the Red Sox stopped winning the World Series, and so he had to move away from there. During this time, he served as Associate Dean of Student Affairs and Educational Programs at the School of Medicine, as well as Associate Dean for Admissions in the School of Public Health. He was Associate Professor in the Department of Social and Behavioral Sciences at the Boston University School of Public Health, and the Associate Chairman of the Department of Social Medicine, Social Medical Sciences, and Community Medicine at the same university. But he's just one of our tremendous leaders in the state in health literacy, and our team just loves working with him. And so Dr. Arthur Colbert is first.
Thank you, Chris. You're very kind. So, when I actually moved to St. Louis, I will let you know that we actually won the World Series the following day. And I brought good weather. The last 2 years I've lived here, my friends say, how could you leave Boston and how could you move to St. Louis? And what about the weather? I think the weather's been great. We've already had snow in Massachusetts. So it's my pleasure, if I can get our slides on. Dr. Hay was supposed to do that for us. Let's see if we can. It's okay. That's okay. We can multitask. Yeah, we're good. Well said.
Got it?
Yes, sir. So it's my pleasure to talk about the statewide effort on health literacy. And Dr. Pleasant, I think, really set the stage in terms of what a complex social determinant of health literacy really is. And we've been given 12 minutes. I'm going to try to stick to that. And the slides have been distributed to you. I've changed them around a little bit. I've eliminated a few of them based on meeting with Andrew yesterday and what he discussed here earlier. So health literacy, pretty traditional definition. I take it from Healthy People 2010. I will add and let you know that in Healthy People 2020, there'll actually be a number of articles and points that will deal with health literacy for the very first time, which is very, very important. The risks for low literacy result in misunderstandings, mistakes, excess hospitalizations, poor health outcomes, and unnecessary deaths. And probably more unnecessary deaths than we probably are aware of. The size of the problem you heard described by Dr. Pleasant. To sum it up, nearly half the population, 90 million adults, and 1.6 million adults here in the state of Missouri. The costs, again, in order to address this problem effectively, to get the attentions of lawmakers and legislatures and the business community and the healthcare industry, you really need to tackle it from the cost. And a study that was done by Dr. John Vernon about 18 months ago here in the United States estimated using aggregate data to be in the range of between $100 and $238 billion. We contracted with him to do it here in Missouri, which is the only state that this analysis has been applied. And the estimated annual cost between $3 and $8 billion a year to the economy of Missouri. So it's not insignificant. It's a huge amount of money that is going towards health literacy. This is just a map of health literacy, and it tries to indicate where we see higher pockets of lower literacy levels and the costs that we see. So again, it's somewhat predictable in that it's around two large urban areas, St. Louis and Kansas City, and the other darker blue is down, I believe, in Greene County and in Springfield. I'm actually learning the state of Missouri. So then Health Literacy Missouri. The Missouri Foundation for Health back in 2005 developed a strategic plan. They went back and looked at the first 4 years of applications to the foundation and realized that a significant portion of them had health literacy as an underlying cause of what people were looking to address. So with that, the board agreed and decided to begin funding, starting in 2007, a 5-year plan that would create what we hope to be a statewide health literacy center that will open its doors in 2009. Our vision is quite simple. We want to be a national leader. We want to be a blueprint for other states to follow. And most important, we want to improve the health of all Missourians. It's very much a collaborative. It's a very interesting, unusual administrative structure. The 4 partners are the St. Louis Collaborative, which are made up of Washington University, St. Louis University, Missouri Foundation for Health is a second partner. Here at the University of Missouri and Missouri State University, primarily it's AHEC centers. The folks that are involved, and I have the pleasure of being able to coordinate the council. So how do we operate? We operate through daily discussions because we all live in different places. We hold weekly conference calls. We meet monthly as a coordinating council. And what's really important is that we work across these institutional boundaries, primarily through committees, in a way that we have found to be extremely effective. There's open dialogue. Early on, one of the first things we realized that through collaboration we could create this group genius effect, that we would be much more successful working with each other, getting each other's ideas, and creating somewhat of a group genius. We come to consensus of priorities, and that we are using right now to create a strategic plan for the Health Literacy Missouri Center to open next year. Our guiding principles, very important. It all centers around engaging our community partners. It's to be inclusive. We want to respond to its needs. And at the end of the day, it's all about relationship building. The consumer is first and foremost. It's really user-driven. We hope it's easy to use, and it will be our goal to keep it sustainable. And because the field is so big, as Dr. Pleasant described to us, our role will be to figure out where we fit into this big complex of health literacy. What's our little niche here in Missouri that we can contribute to this growing field? I'd like to spend a few moments and tell you a little bit about activities that we have been engaged in the past 2 years and what we expect to be able to continue to do. So we began by trying to identify what are the health literacy needs and concerns of Missourians. Again, across the 3 different centers, a group conducted in-depth interviews in different organizations and different counties and really tried to determine what were the needs here in Missouri. A big ongoing project has been to go to the literature to try to determine what are the resources that are out there today. We have identified nearly 10,000 different kinds of resources. You saw the proliferation of articles that were just published that Andrew presented to us earlier. It's the same thing for all kinds of other types of resources that are out there today. And the trouble is, none of them do we know if they're evidence-based, do they have any type of backing, seal of approval behind them. So our goal is to really try to classify them by type and develop some type of criteria for evaluating their effectiveness. We convened a health literacy conference back in May with the Center for Disease Control. We were one of 4 sites across the country that were able to do that. I think some of you, many of you, were probably attended that meeting and really began to put Missouri on the map in terms of our interest and commitment to health literacy. Folks here in the School of Journalism, many of them are here. We've conducted a national survey of healthcare journalists, and one of the impressive findings that the group found was that healthcare journalists knew very little about health literacy. And I think it's our intention in the next year and a half to actually orchestrate a workshop for healthcare journalists and to be able to bring them here and to use the good faculty that we have and really begin to explain in terms of what this health literacy field is so that they will be better able to report it as part of their ongoing work. We also conducted extensive open-ended interviews with health literacy leaders throughout the country. And again, all this has gone into the formulation of what it is that we will do as part of our center. A big activity is the development of demonstration projects. We are completing our first year of funding for those, and it's really our opportunity to get the community engaged in very creative ways to deal with the health literacy issue. To date, we have funded 8 projects. There's the telehealth interpretation projects. There's the health literacy education project using the AHECs. Back around St. Louis, we work with school districts. We have worked with the YMCA, the HIV/AIDS group, and 2 projects that we've recently funded that will deal with adult literacy. So again, realizing that it's bigger than what we as three institutions can bring to it, we really try to engage our community and partners, get them involved, and provide support. The support is 2 years in length, and the projects can amount to up to $300,000 in funding. You can approach the various resource centers. You can approach the people at the foundation for the guidelines and how one applies for those. But we really encourage people who are sitting here today, those that you might know that are working in this field, to come forward, share your ideas, get involved, and see if we can't support some of your ideas to move health literacy forward in Missouri. We continue to work very hard at developing a community advisory network. Again, it's really important to know our audience. You heard Dr. Pleasant begin his talk that way. And it's something that, although people think we do a good job at, I worry because you can never do too good of a job. You need to be in conversations and discussions with the community that we're trying to serve. And we try to do that both in urban populations as well as the rural community that we serve here in Missouri. One thing that we have started to do and roll out is our health literacy awareness campaign across Missouri. And again, a subcommittee of our communications group, many of them are housed here within the School of Journalism, we have begun to develop strategic press releases. And each press release begins with a template that you see here on the left side of the screen. And we localize it for the different regions in Missouri. We add graphics. We are in different types of research, and then we release it in a way that we hope, by using local quotes and local figures and statistics from different communities, that will better help get these articles published in local papers. It's really important, as we sit here today and try to grasp with what is this thing called health literacy, that we can raise this awareness level among the people here in Missouri. And we plan to roll out these strategic communications once a month, so far they seem to be effective. Another big part of what we're doing is health literacy surveillance. It's really important as we move forward. This is not something that we expect to see results in the next 2 or 3 years. We're really talking about 5 and 10 years and decades from now. We need to ascertain what is the health literacy level of the general population. So to do that, we are developing a survey that we will probably administer here in Missouri in the year 2010. At the same time, we would like to develop the same type of base for healthcare providers, broadly defined, not simply physicians, but all healthcare providers. And again, we are working to develop that survey, which we expect to also administer in the year 2010. Our target population for our resource inventory, our community-based organizations, healthcare providers, adults with low health literacy. So the resources that we talked to you earlier about, really important that as people want to access them, they're easily to get to, they're well organized, they're user-friendly, and they meet individual needs. So for example, if you think about Home Depot and you have a problem in your home and we need to go fix it, if we think in terms of the Health Literacy Depot, and if we go to our site that we expect to open in December of '09, and we click on healthliteracymissouri.org, I showed the slide to folks the other day, and everybody went to it right away to see if it's not live, okay? This is simply our expectation, although we do own the domain to it, so when we are ready to open it. You click on Health Literacy Depot, and you would be able to choose from a drop-down an area that would be of interest to you that you want to work on, you want to fix. For instance, how do you develop plain language documents? You heard Dr. Pleasant talk about creating a shame-free patient-provider environment, developing appropriate signage within your institution. So we would provide for you the tools to be able to create what it is you need to do to address that. At the same time, because we're working on the different surveillance, we would have a number of items that would be part of this toolbox that you would be able to create for yourself and be able to evaluate the successes of your initiatives. So we expect this to be a big part of our ongoing efforts. When we talk to people around the country, they applaud it in that it's something that is desperately needed because there's so much out there. And particularly if we're able to determine and evaluate and add some value to what it is that people would be using, we expect it to be a big part of our activities in the years to come. And another big area that we will devote time to is dealing with the health professions. Again, this is not, we don't view health literacy as the patient's problem. It's really a systematic problem. It's really something that we need to address in terms of systematic change. And one way to begin to do that is to, again, bring awareness and best practices to the different health professions. So to do that, are three areas that we will do this. One is to work with our AHAC spine that's over the 20 years, which has so well positioned here in Missouri, to work with these young people prior to even beginning college, in high school, raise this kind of awareness, as they do their AHAC activities with students in college, to continue to include health literacy as part of what it is that we bring to our AHAC students. And then to move up and to bring to the table the different health professional schools here in Missouri. We are strategically identifying them, trying to get them to the table, that they might someday agree to realize that 3 hours is all we might ask for. You know, how do we bring awareness to this issue, and how do we provide best practices vis-a-vis nursing, pharmacy, medicine, or whatever, and have that lecture delivered by that charismatic person within that profession. I've had the opportunity to speak twice to medical students here in Missouri in the past year, and entering first-year students, and like most of us, completely unaware of the problem. But what was encouraging is that they viewed themselves as part of the solution. By being aware of this big problem, the complexity of it, and their role as a future provider, they saw themselves as being able to address this problem. And then finally, to work with the health professions that are out there practicing healthcare today. And really, again, through best practices, through professional organizations, work with them to try to include as part of not only their one-on-one dialogue with their patient, but really in terms of how they organize their practice of medicine. So my hope would be 10 years from now to be able to stand back up here, okay, and we would see a totally different healthcare system here within Missouri in terms of the setting, the way it's arranged, the way that we communicate with our patients, in a way that, much like Dr. Pleasant described, that people would actually be able to understand the information and make correct decisions about their health. So our next steps really are to move forward in partners with the people that are here in this room today that are broadly defined by show of hands earlier as we started our presentation. So with that, I'd like to thank you, and we'll be here to answer questions.
I think we heard Dr. Colbert volunteer to be a speaker at the 16th Annual Health Policy Summit in 10 years from now, so we'll make sure to bring you back at that time. Bear with me for just a second here. I'm going to do my due diligence and bring this up. I feel like we just accomplished something. So, our next speaker is Dr. David Fleming. He's the director of the MU's Center for Health Ethics and a professor of medicine and health management informatics, and a key partner with our Center for Health Policy, well known to all of us and very well liked, and we're just pleased to have him here today. He specializes in geriatric medicine and has had a large following of patients from Moberly, where he formerly practiced and where he was raised, just a few miles north of here. He received his Bachelor of Arts degree from the University of Missouri in zoology, and then went on for a master's in microbiology, so he did know what that anthrax definition was, and then his medical school education. He later went on to do a 2-year fellowship in primary care research in clinical bioethics from Georgetown University. He's currently the governor of the Missouri chapter of American College of Physicians, and I just love that title, so from now on I'm calling you Governor, okay? And but David's students love him and enjoy working with him, and he's got this great ethics consult service coming out of the University of Missouri, and has a lot of really interesting initiatives to share with us today. So, David, welcome.
Thank you. Thanks, Chris. I appreciate that. I guess I should start with a couple of warnings. One is that, as you can probably tell from my voice, I've got a bit of an upper respiratory thing that my dear wife shared with me a few days ago, and I'm getting over it now, and I've almost forgiven her for that. But if I suddenly dash for the water or dash for something to clear my throat, I hope you understand. The other is to my panelists. You'll notice that behind you is about 3 inches of stage that's left, and when you scoot your chairs back, there's about 1/4 of an inch left. And I've seen more than once a chair disappear off the back of the stage. So if one of us does that and doesn't pop up right away, you better call 911 because we're injured. You know, we're dealing in an initiative right now in partnership with the Missouri Foundation for Health and the American College of Physicians Foundation that's looking at a problem that's epidemic in our country, and that is diabetes. And the reason we chose this is because of the very nature of the burgeoning need to address the needs of our patients in being able to deal with this concern and this issue themselves at home, to be educated, to deal with reasonable levels of knowledge, and to self-manage and to be successful in that regard. And it's a major challenge, especially when we also recognize that many of those individuals with diabetes that are coming into our adult population are presently children who have an adult form of diabetes, which is the first time in history that that's actually occurring. And many of you who deal with children realize that that's becoming an increasing concern. Specifically, what we're going to be talking about here is a program. It's actually a research and also a service intervention in the state of Missouri that's being sponsored based on development from an instrument that was created by out of support by the American College of Physicians Foundation and is led by a research team actually out of Chicago. But chose Missouri because of our demographic and the concern regarding that. The Missouri Foundation is funding this. We're very thankful for that. Art, thank you very much. And Art is actually helping us a great deal in coordinating this process. The ACP Foundation has been very involved in the initial development of this. And the health literacy program, which is led by Mike Wolf, who's been to Missouri several times now to help in coordinating this, is the team leader for the implementation process. The guide itself, which is pictured here, was developed by ACP Foundation with having gotten together a group of national experts to basically talk to patients and talk to various providers about what the problems are, what needs to be done, what kinds of information need to be provided to patients, not to providers, but to patients to assist them in the self-management of their disease process. They obviously reviewed the literature, as all good researchers do. They looked at what was available, and what they came up with was a really neat self-management tool, which, by the way, is available online. You can get it now. acponline.org is the site you can go to get that. This is the team that actually developed this. You'll recognize some of these individuals. Terry Davis led the team. She's a very dynamic, vivacious health literacy expert out of LSU. Louisiana is a state that has been hugely impacted by this problem, not only the problem of diabetes, but also the problem of health literacy. It's probably the most challenged state in the union. And Mike Wolf was part of this team as well, who is our PI on the process. The guide itself is available in Spanish as well as English. It utilizes best practices, which pertains to photos of actual food. These aren't drawings. This isn't artwork. These are actual plates of food, and compares portions of what people normally eat and what they ought to eat to assist patients in actually doing the right thing when they're at home in their own kitchens. It's at an appropriate reading level, which is at about a 6th grade level, and it has content that is easily accessible. And by that I mean it's easy to read, it's in large print, and it's in short sentences and phrased in a way that anyone can really understand. It's focused on action planning, not on the disease process itself, and it's got real people. The photos are of real people who they actually talk to, who have the disease, who are actually implementing these actions, and they tell their own stories about how they're utilizing it. This is a randomized controlled trial. Our hope is to recruit just over 1,000 patients, about 1,100 patients at 3 sites, which is about 360 per site. I happen to be the site PI for Columbia, which is our mid-sized community that's involved. And we have 3 basic outcomes to really assess the individual's growing level of knowledge in their disease, the behavior, the actions, the planning of those actions, and how well they follow through on those. And then, of course, glycemic control, which is using one blood test, which is the hemoglobin A1C. And that is the blood test that actually averages your blood sugar over about a 3-month period of time. Very easy to do, and it gives very accurate and clean data in terms of the scientific component of that. It's a 2-pronged approach. It is focused on the patient, as I said, not the disease. So it's focused on what patients do, not what the disease is doing. And it's on a need to know. It doesn't give a lot of information that really is not going to be helpful and may even be confusing to the patient, which many of the guides and the literature have out there right now. The action planning is to teach patient practical ways to change health behavior that will both inspire confidence, encourage them that it can be done, to set reasonable goals, to take baby steps, not giant steps, and not be unreasonable. In other words, don't go out and try to lose 30 pounds. Let's maybe lose a couple of pounds in the next few weeks, and then we'll lose a couple of more after that. And then to give them ways to actually solve those problems. And we're going to actually use that information that they provide us to help further develop this as we move along. And this is just an example of action planning. Again, this is a picture of one of the individuals that was actually involved in this. Very specific, easy to achieve short-term activity as a patient. Goal being lose weight. I'll walk around the block before or after dinner. Another example was, I'm only going to eat half of that Mars bar before I go to bed tonight, instead of eating that whole Mars bar. Setting reasonable goals where they can actually incorporate that into the lifestyle that they have. These are the 3 sites, Kirksville, St. Louis, and Columbia. Kirksville and St. Louis are federally qualified health centers. The sites in Columbia are both family practice and an internal medicine site, sites that care for a large number of underserved. And although it's not federally qualified, that has a very similar demographic. Each of these 3 sites has 3 clinics, and we're going to talk about what these actually do, but there are 3 different interventions at each one of those. There are 2 models that are actually being investigated, 2 kinds of interventions that are being investigated. And I must tell you that the goal here is to provide a way for this diabetes guide, this self-management guide, to be inserted into a practice, a community practice, without added resources being required by that clinic and without added hassle factor to that clinic, so that it can be a user-friendly process, so it can be brought in to encourage these clinics and these providers to actually do this, which has been a bit of a challenge because, especially for the Carve-In site, which is where the diabetes guide is actually distributed by the nurse to the patient, and the nurse or the staff person designated for this does the follow-up calls to check on the patient regarding their action planning. It does add a bit of time to that, and that's been one of our challenges in actually implementing this study. The carve-out is where the diabetes guide is given to the patient by the clinic, and then somebody in Chicago calls them and talks to them about it and asks about action plans and sets further action plans in the future. And then the control site is just usual care. We just monitor the patients and provide usual care. These are the action points. The intervention is nurse-driven. It's not physician-driven, which I view as a good thing, because the nurses are typically the ones that spend more time with the patient. They're the ones that communicate with the patient on a day-to-day, week-to-week basis, and they're the ones that do most of the education for our patients. That's certainly true in my clinic, and I'm sure that's true in most of the clinics that you all are involved with. You can see the points here, the action points in terms of baseline, and then follow-up as it relates to action planning. Set an action plan, follow up. Did you follow through with it? If not, why? Let's set another action plan. I'll call back later. Did you follow through with it? If not, why? Setting reasonable plans. In addition to this, we have a research specialist who has an array of interviews that she does with them that measure knowledge, measure confidence, measure health literacy, and look at various other kinds of outcomes that we're interested in at baseline, 3 months, and at 6 months, but that's different than the intervention itself. The carve-in intervention is underway. We have been fairly successful so far in the 3 sites. We've got about 25 patients who have completed their action plans across these sites. And on the carve-out intervention, which is very similar, it's basically the same intervention for the patient, except that somebody a few hundred miles away is calling them to find out how well they're doing. And we're going to compare those two. We're going to find out if they're equivalent, if one is more successful than the other, and we're also going to find out the usability of doing that, because we may actually find out that we can do it from a distance and we don't have to do it locally, and it may be just as effective. So far, we've got about 150 that are actually enrolled, but we've certainly got a ways to go, and hopefully next year I can come back to you and tell you that we've got some really great data to share with you, and so we can educate ourselves about what we need to do for our patients. So thank you very much.
Thank you, Dr. Fleming. We appreciate you being here. And our next speaker is Lisa West. She is a senior health coach with the St. Louis Integrated Health Network, and she's been there since 2005. I'm going to take a deep breath and tell you what the IHN is. Okay, so the St. Louis Integrated Health Network is a permanent regional network of safety net providers partnered to coordinate and integrate primary and specialty safety net services to strive for quality, accessible, and affordable health care services for all St. Louis residents with an emphasis on the medically underserved. And it's a long sentence, but we all know what that is, and many of us are engaged in those activities. This is good work. Ms. West has 10 years of experience working within the St. Louis community as a job coach, as a health liaison, as a case manager, a school-based outreach coordinator, and a community outreach worker. So unlike some of us who can't decide what our careers are going to be, she has long experience in helping people navigate complex systems. And so it's thrilling to have her here to talk about health literacy, one of those areas in which navigation can be very difficult. She has formal training in the American Heart Association's Heart Health Program, the Lung Association Smoking Cessation Program, the Open Airway Program, also from the American Lung Association, and a CPR certification. She graduated with a degree in occupational therapy in 1999 and couldn't get enough, so she's going back to school to get her bachelor's degree in healthcare management. And welcome. It's great to have you here.
Well, welcome, welcome. Today I'm here to talk about a great program that we have in the St. Louis area. It's called the Health Education Literacy Program. First of all, before I get started, I'll give you the reason why the Health Education Literacy Program was originally began. What is IHN? The St. Louis Integrated Health Network was formed in response to the recommendation by the St. Louis Regional Health Commission. The IHN focuses are to improve access of affordable, high-quality care for vulnerable patients, including underinsured and uninsured patients. To improve the health care status of our community through coordination of care across primary care and specialty providers. And we also to develop collaborative programs to improve health care status for our patients. Now, the IHN members organizations include 8 of the major outpatient safety net providers who collectively serve over 2,000 uninsured and underinsured residents in the St. Louis City and county area. These providers account for 4,000 safety net patient encounters per year. There are 4 federally qualified healthcare centers, which are the St. Louis County, Grace Hill Neighbors, Myrtle Hilliard Davis Health Comprehensive Healthcare Centers, and People's Healthcare Centers. We also service St. Louis Connect Care, which is a urgent care specialty unit as well. And then we talked about St. Louis County Department. And then we also have Washington University and the St. Louis University of Medicine. Now, what is HELP? HELP, of course, once again, is a health education literacy program, and the St. Louis Region's collaborative health literacy program in health care and community settings. A culturally appropriate health literacy program that involves lay health coaches. These are the individuals that work with the patients. And we focus on those that are greatest in the health disparities, those who are medically underserved. Now, the population and HELP, we have African Americans, Bosnians, Caucasians, Vietnamese, others, and Hispanics. Now, within these targeted populations we currently serve, our goal is to reach 100% access to health care. We work with the targeted population to a degree in which individuals have the capacity to obtain, process, and understand basic health care information and services needed to make appropriate health care decisions. Now, we address patient treatment non-compliance, missed appointments, unnecessary visits to the ER, improper taking of medication, patient dropout rates from the healthcare system, and we also work with the providers to enhance their community with their patients. Health literacy is defined by the U.S. Department of Health and Human Services as the capacity of an individual to obtain, process, and understand the basic health information, services, and to make appropriate health decisions. Some of the symptoms of low health literacy are the patient treatment non-compliance, missed appointments, unnecessary visits, incorrect timing or dosage of medication, patient dropout, and failed provider-patient communication, and then a greater potential litigation. Now, the HELP program, how does this work? This great program works with its members and patients to become informed and engaged in self-management of their chronic conditions. The vision of the health coaches and the health coach program are to reduce disparities within those targeted populations, such as the African American communities, Bosnia, Hispanic, and Vietnamese communities. We also want to improve access to health care within those targeted communities. Now, before I go on the next couple of slides, I'll kind of summarize those as well. Our project is very unique because we accompany the patient through the entire process as a whole, which means we have to address social issues as well, like patients locating employment, housing, and utility assistance, and the patient is unable to focus on health issues if they don't meet the needs. So we can't work with the patient and expect them to take proactive measures if their lights are out, if they don't have any food or transportation. So this health coach, we work with the networks and the clients to a degree in which the individual has the capacity to obtain and process all of the information and some of the understanding that they need to be proactive. What do the health coaches do? Well, we talked about we accompany them through the process, and then we also work with patients within our own community that would normally not have access to health care through our outreach efforts, such as presentations within religious organizations and neighborhood meetings. This has been very, very successful because the health care within the communities are consistently unaware and out of touch of what goes on within their own community, so we bring awareness within their communities. And like I said, the next couple of slides, I'll just go ahead and summarize, so I won't take too much more of your time. We also visit with the patient and the health care and appropriate medical staff with meetings. So basically what we do at the beginning process, we meet with the primary care doctor or a specialist to make sure the patient is well informed and they understand why they are meeting with the doctor, they understand what their conditions may be. We do home visits when necessary to increase the trust between the patients and ourselves. And the biggest thing about our program is that we have been able to work with the patient one-on-one to build that trust, so they'll be more open to talk to us about some of the health concerns that they may have, why they don't go to the doctor, why they don't take their medication. And just coming into an office, visiting them for 5 or 10 minutes, they're not going to be open and honest with us. So we sit in the home with them. We actually sit down and let them know that we are an advocate for the patient. We want you to become more aware and proactive. So by doing that, we have the capability and the time to build these ongoing relationships with the patient and build that trust. We work with the patient also to increase their understanding of their treatment plans as well. For example, for medication, I talk about the 5 W's: who, what, when, how, where, and why. Who prescribed the medication? What is the medication for? Do you understand? When should you take the medication and how often? Some of the prescriptions that I've talked to, they say take twice a day. So does that mean take it at 8 o'clock in the morning, at 10 o'clock in the morning? So we work with the patient to educate them on their treatment plan. How should they take the medication as well? Where should they store the medication? And then most importantly, we educate the patient to understand why they're taking the medication. So many of the patients that we deal with, they just take the medication, and their biggest response when I ask them, why are you taking this medication? Oh, it's just what the doctor prescribed. So I tell them, I said, well, you know, if the doctor told you to jump off the bridge, would you jump? No. So I really work with them to educate them on why they're taking the medication. Also, we work with the patient through system navigation. For example, understanding the difference between a primary care doctor and a specialist doctor. Also, the difference between the emergency rooms and urgent care centers. And one of the biggest problems that we have in the community now is that so many people are accessing the emergency rooms as their primary care home instead of building a relationship with the PCP. And one of our other goals in the program is to drive the patient into the primary care home to build a relationship with the patient as well, and not to utilize the emergency rooms. We also have community referral coordinators that are actually housed in St. Mary's Hospital in St. Louis and then Barnes Jewish Hospital in St. Louis. And their primary focus, they focus on the patients that come into the ER that are non-emergency visits, and we receive a lot of referrals that way. From that point, we'll follow up with the patient, talk to the patient, and figure out why they're utilizing the emergency room versus the urgent care center, and have they ever heard of an urgent care center as well. We work with the provider to ensure that they fully understand the patient and the patient's culture. Some of the patients don't go to the doctor because of religious reasons or background. Within the Hispanic community, I found that some of the patients, female patients, won't go see an OBGYN without permission from their husbands. It may sound abnormal to just average Americans, but if you're Hispanic, that's within their culture. So we make sure the doctors completely understand where the patient is coming from. Some of the doctors tell me all the time, why won't they just take their medication? Well, it could be because of religious issues as well. We learn the patient's preferences and concerns and their input on their the healthcare system overall. And what we found is with some patients that are within the communities that we serve and with their own communities is that they do not go to some of the federally qualified centers in their own community because they have a cousin that may work there or a neighbor down the street that they don't work with, or they just had a bad experience at that particular healthcare center. So we work with them to get their feedback and their input on why they do not utilize the federally qualified healthcare centers in their community. We also provide transportation if needed, resources for transportation. We also provide transportation and then interpretation for our non-English speaking patients as well. We have been very successful working with the LAMP organization and providing that. So once again, we work with the patients to make sure any barriers that they may have, they do not have after working in the Health Coach program if possible. And also with the PCP as specialist and patient, we establish and record an agreed upon and acceptable health managed goal for the patient. So if the doctor is working with that patient to decrease their weight, if obesity is an issue for the patient, we work with them on a regular basis to help them meet those goals. Once again, it just goes on. The slides are a little more in detail afterwards if you want to know the complete step-by-step process for it. And then also, once again, we get that provider feedback from the patients as well and the doctor about our program and for the patient. More of our responsibilities is that we also query the patients in regard to how much the patient understands about their process, their chronic disease, the overall healthcare system as well. That's very, very important because a lot of the reason why patients do not go to the doctor, do not take medication, is because of literacy issues they just don't understand. What are a health coach's goals? Of course, we want to decrease the patient noncompliance, missed appointments, unnecessary visits to the emergency room, improper taking of medication and patient dropouts, and then failed provider and patient communication. I give you a quick story. I worked with a elderly lady who was 85 years old. I went to do an assessment of her, and when I went to her home, she brought me this huge bag of medication. She was taking like over 30 different prescriptions. Well, part of those prescriptions were birth control pills. Now, I've never known an 85-year-old person to have to take birth control pills, but unfortunately, she was unable to read or write, so she just thought it was part of her medication. And then I was asking her, where did you get these from? Well, she had a granddaughter that used to live with her that had birth control pills, and she left them in the bathroom. And one day, when she went to go to the doctor, he said, well, bring all the medication that you're taking. And unfortunately, I don't know if the doctor didn't see this, as obviously he didn't, but she was taking birth control pills, and then also she had been taking 4 different high blood pressure medicines that were prescribed by 4 different doctors. As part of our feedback and communication, once again, we are constantly working with the patient on a regular basis and the PCP through surveys, personal interviews, and case studies. We continue this process until the desired level of health status and literacy is achieved. What are our results to date? A qualitative evaluation by the International Institute finds that health coaches help patients address system access and navigation problems. We also become trusted resource and provide valuable information related to disease management for the individual patients. Initial accomplishments, 57% of patients were without primary care providers before working with a health coach. Out of these patients, 81% currently see primary care providers. Of the chronic disease patients, 1% reported having a self-management plan prior to working with a health coach, and after working with a health coach, 27% of them now have a management plan. How will the IHN define and measure success? Does the patient demonstrate working knowledge of system navigation? Do they see a primary care doctor on a regular basis? Are they proactive in asking the doctor questions on their visits? Do they understand a self-management plan? Do they have insurance if they're eligible? And then also, too, if we work with a patient who does not have insurance, we do work with them to help fill out Medicaid applications if they do qualify, or find other resources or educate them on the sliding fee scales. Also, does the patient, he or she, take their prescribed medication? Do they exercise on a regular basis? And also, are they enrolled in a chronic care program? And also, do they show improvements in their key chronic disease measurements? Also, with the provider, does the provider communicate and encourage dialogue with the patient? Do they support the patient in setting self-management goals? Do they treat the patient with dignity and respect? And do they understand cultural issues that the patient may have and impact with his health literacy? Now, in order to make this program more successful, we have to also address barriers like transportation that we currently work on with the patient, getting to and from the doctor, educating them on systems like Bi-State, Call-A-Ride, the MetroLink, also financial barriers as well. We help enroll them into prescription assistance programs with co-pays to the doctor. And then also, once again, we talked about language as a barrier, so we do provide the interpretation when needed. We also have to address patients' lack of trust within the healthcare system. And then we also, because of that, and those other things we talked about earlier, we also have to empower and educate the patient, increase them constantly on their health literacy, causing the patient to be confident. And with confidence, it increases their patient's trust level within the community and then with us overall. In turn, that patient becomes more proactive. They're able and willing to take preventative health care measures to become a healthier person. And that is what we consider success. We've made a difference in one human being that would affect an entire village. Thank you.
Thank you, Ms. West. Our last speaker is also well known to us and one of our key collaborators at the Center for Health Policy. Ms. Gabby Flores has over 10 years of experience working in the field of human services, specifically with immigrant and refugee populations. Oh, I did something, sorry. There we go. It's got a mind of its own. Step back from the computer. She's currently the Director of Interpreter Services for Truman Medical Center in Kansas City and also the Chair of the Truman Medical Center Diversity Council. She is a certified instructor of a Bridging the Gap interpreter training program for healthcare interpreting programs for Spanish interpreters. Actually, I'm screwed that up. She's a Bridging the Gap interpreter training program certified instructor. She's also adjunct faculty with the Johnson County Community College for healthcare interpreter provider programs for Spanish interpreters. She's been active in educating healthcare providers for many years on their legal obligations to provide language services to patients with limited English proficiency. She holds a bachelor's degree in anthropology and a master's in business administration, and she's recently completed the American Hospital Association's and Health Research Education Trust Cultural Competency Leadership Fellowship. So, welcome. It's great to have you here.
Good morning and happy Halloween. I want to thank Gwen Rotterman for inviting me to come today. I wasn't quite sure I was going to be able to successfully link language access and health literacy, but those of you that know Gwen know you cannot say no. So there's, I will try very hard to kind of connect the dots between language access. There's some really obvious linkages and some that are a little bit more subtle. So first off, I think it's valuable to define what language access is to us at Truman Medical Centers in Kansas City. Essentially, as indicated, I oversee the Interpreter Services Department for our hospital, and our whole mission, the whole vision of our department is to provide language assistance to limited English patients as well as those patients that are deaf or hard of hearing. Those of you that are familiar with language access know that the Office for Civil Rights mandates this. We must provide free language assistance to any patient or program participant that requires it, and we are to pick up that tab if we're a Medicaid or Medicare facility. It also applies to any other type of organization that receives federal funding. So, for example, if you're a safety net clinic or if you're even Division of Family Services, you have an obligation and an expectation to provide free language assistance to patients with limited English or participants. In addition, the guidelines that are set forth by the Office for Civil Rights require that we utilize trained, screened, and qualified interpreters, that we cannot just borrow the janitor from down the hall. We cannot utilize family members. There's obviously certain implications there when you're utilizing family members. You never know if your message is being delivered accurately and completely, and then that it violates that patient's right to receive private and confidential care. For our department, and for most other hospitals, we have an obligation to provide language access 24/7. And this is very challenging for hospitals because you never know what you're going to get, when you're going to get it. Recently in Kansas City, we've been having an influx of moms from Micronesia who speak a very small dialect of Chuckese who are coming to labor and delivery. It's been really virtually close to impossible to try and find interpreters in the local community that speak that rare form of dialect and that are available at 3 o'clock in the morning to deliver a baby. So we've been fortunate to utilize our telephonic interpreting system and can find many Chuckese interpreters in Hawaii. So we connect up and have that access for those moms. But it's a challenge, especially when you never know who's coming in. In addition to that, in order to not discriminate against those who do not speak English or who have limited English proficiency, we can't make, primary care clinic Spanish-speaking 3 days a week. What that does is creates disparate impact. So they should be able to come to clinic whenever they want and have equal access to clinic. And important, I think, to today's conversation, in terms of the scope of our work, is that we also do document translation. And I noticed Leslie's over here, so I want to plug for healthtranslations.com. But we internally at Truman, our department also provides all of the translation of all of our documents. The term vital documents is a definition that, again, is part of Office for Civil Rights policy guidelines. And that means anything from an informed consent for surgery, which is written at, PhD level language, all the way down to, like, say, diabetes education, which is much more of a realistic level of language. Just to give you an idea of kind of the volumes of our organization, last year, Truman, and this is only at our Hospital Hill site, which is an urban safety net facility, we provided 41,200 language interpreting sessions last year. With about 18 people. So those of you that can do FTE calculations really fast, that's a lot of running per day. All we do is interpret all day long. We don't share our job. We don't do half-time clerking and half-time interpreting. We have enough volume to warrant 15 and a half FTEs for our department. We provide, of course you would imagine Spanish would be our #1 language. People are surprised that Arabic and Somali are also significant communities in Kansas City. Just to kind of start maybe framing it up a little bit to discuss linking language access and health literacy, just to kind of give you an idea of, language access is going to be very, very different in a suburban or a rural hospital setting. But, and we have both. We have another sister hospital that is a suburban hospital, has very, very different language needs. But Hospital Hill, Truman Hospital Hill, is an urban core safety net hospital. We're relatively small. If you think about the number of encounters we had versus the number of acute beds that we have, we're a relatively small hospital. We have 60,000 emergency visits, and I think the previous presenter spoke quite relevantly about folks utilizing emergency department as their primary care. We see and feel that daily. We've been on diversion probably 50% of this last month, which means we've got no beds available. Can't bring any more additional people in because we can't bed them. And then importantly, although we're a safety net hospital, we're also one of the primary safety net clinic systems within the Kansas City, Missouri area. So we do about 250,000 outpatient clinic visits, and that includes primary care and specialty care. An important piece of today's conversation about health literacy is really assessing the diversity of your community. Kansas City is quite diverse in the sense that, well, it's diverse in many ways. First and foremost, because we have a bi-state area. So even though we're located in Kansas City, Missouri, we have lots of immigration, for lack of a better word, between Kansas and Missouri. And so Kansas City, Kansas, for example, has roughly 25% of its urban core are relatively new recent immigrants from Latin America. And a lot of those folks migrate back and forth to seek care where they can get it. In addition to that, we're also a refugee resettlement community, much like St. Louis. So those numbers of Arabic speakers and Somali speakers, those folks are mostly refugees coming into our community. And then in terms of literacy, we have found that the majority of our Somali patients, just due to the war in their home and their relocation to refugee camps in Kenya, most of them are illiterate or have very low literacy in their own native language of Somali. Not to mention that it's a new language anyway, so it was only really started to be written in the 70s. So in terms of communicating an informed consent for surgery and trying to translate that into Somali, it's really a waste of time and a waste of money to do that. So we have to work very closely with our interpreters to ensure that patients have enough information and can make good decisions prior to having procedures and things like that. Likewise, with other refugee populations that we work with, mostly Sudanese and Iraqi, very, very different, both Arabic speakers, but very diverse in and of themselves. Again, and the majority of our patients from those populations are female, many of whom are illiterate in their native language, so they cannot read and write in Arabic. Learning English when you're not literate in your own native language, you're looking at about 12 years to gain basic proficiency in English. And that's 12 years of like rigid, disciplined going to ESL classes. That just kind of gives you a picture of the kind of populations that we're working with at Truman. Importantly, I kind of mentioned a little bit about Kansas City, Kansas and its changing demographics. Within Truman itself, we've seen about a 2% increase each year in the number of Hispanic moms delivering. So right now we sit at about 27% of our births are to Spanish-speaking moms, so to Hispanic moms. And I would venture to say that probably 95 to 98% of them are monolingual Spanish only. meaning they don't have any English competency at all. So they're relatively new immigrants. And just anecdotally, from our interpreting staff, we would venture to guess that many of our patients are from rural communities, so they're not urbanites moving from Mexico City, for example, to Kansas City. Most of them are rural folks coming to Kansas City. Many of those folks, we estimate, have probably a 4th grade education at best. That's the majority of them. Health literacy is an important topic when working with patients that have limited English, because you can expect that their basic literacy is going to be less than mainstream population. And then taking it a step further, what we're experiencing in Kansas City is an important demographic shift within our Hispanic community. We have seen shifts in the type of immigrant that's coming to the United States. For example, right now we have about probably 6 to 8 births per month of women that are Mexican, but they do not speak Spanish. They are Mixteco Indians, and they speak Mixteco language, which is very, very different than Spanish. Very difficult for our Spanish interpreters to try and have a meaningful communication with those patients, and to ensure safety and confidentiality and all of those things, because oftentimes we have to work through a family member in order to communicate a message, just simply because there's really no resources available. So that changing demographics, it's daily, it's occurring, it's like overnight we're seeing this population that we didn't see 6 months ago. And we're not really sure why, but we're trying to scramble and get resources together to be able to provide effective, interpretation services for them. An important thing that I think is relevant to those of you that come from a hospital setting, how many come from hospital settings? 3? Okay. Well, we won't spend much time on this then. But importantly, those of you that work at hospitals have the fear of God when you talk about Joint Commission. They are the accreditation body that comes in and deems your hospital suitable for caring for patients. Well, the Joint Commission's just recently completed a study on language, culture, and hospitals, and their task at hand right now is to put forward some recommendations that hospitals will have to meet standards relative to cultural competency, language access, effective communication with their patients. So it's for those that work in hospitals, that means we've got a lot of work to prepare to be able to meet those standards when they are implemented. And we're probably a year out, so we've got a little bit of time. Reduction of health disparities, I'm going to save that because the next slide's about that. But that's one big link between language access and health literacy. And then lastly, just kind of an important note that language access goes beyond just your limited English patient populations. It touches other vulnerable populations, which would be patients that are deaf or hard of hearing. Right now we're trying to really develop policies and appropriate practices in working with patients that are blind or have low vision, cognitive or speech impairments. So these are all patients that most likely have low literacy and low health literacy, and therefore fall through the cracks more frequently. In terms of kind of our language access and Truman's overarching diversity initiative, our goal is to reduce health disparities within our facility. First thing is to acknowledge that they exist, which is sometimes difficult for hospitals and facilities to do, but this report, Unequal Treatment, put forward by the Institutes of Medicine, tells us that absolutely racism exists in the healthcare system and that disparities are very much present and will be difficult to eradicate. These are some of the recommendations that the Institutes of Medicine discusses in their report, which are all, to me, relevant to health literacy and language access. Obviously, if you speak Burmese and your provider does not, there's a big communication gap there. You have to be able to enhance that patient-provider communication and then subsequently enhance the trust that exists there. When they can't speak to each other, that just simply isn't there. And so we as interpreters have to be able to bridge that and facilitate that communication more effectively. And more importantly, at this day, there is an emphasis on quality. So when we have interpreters facilitating communication between patient and provider, the whole notion is that the message is being delivered accurately and completely, and that's a really important piece that I think is being emphasized right now at the national level, that it's not just okay to get 85% of the message transmitted. It's got to be absolutely flawless. So that's really hard. When those of you that are bilingual know that that's a hard thing to do. Strengthening patient-provider relationships is another recommendation to reduce health disparities. Patient education programs, which we've kind of discussed earlier today, this morning, those have to be, not only do they have to be at a level that the patient can understand in order to make behavior changes that subsequently impact the health outcomes, but they have to be able to, they have to be culturally sensitive. They have to be, when you think about, I don't know, portion control or food choices for a diabetic patient, your Mexican Mixteco patient's going to choose different foods than your mainstream Anglo Joe Smith from the Midwest. And so those kinds of things need to be considered when you're developing patient education programs in your facilities that are what we call class appropriate, so culturally and linguistically appropriate services. And then again, one other recommendation that the Institutes of Medicine recommends to reduce health disparities to support interpreter services at a facility kind of culture level of your organization. So it shouldn't just be like a little program that sits at the corner. It needs to be infused within all of your operations. We've been around, our department's been around for 10 years, and we still struggle with it. We're a teaching hospital, so it's a revolving door. And so we're constantly re-educating new providers, new students, all of those folks on the most appropriate use of interpreters and how to best communicate to patients having to go through a conduit, which is sometimes difficult. Some of our challenges that we have had in terms of being able to provide effective language services and then impacting the health literacy of our patients. First and foremost is that we are not a revenue generating department. We only spend money, but we avoid risk, which to those in legal, really, they appreciate that. It is sadly, it's a federal mandate, but it actually comes with no financial incentives at all. No funding stream, nothing. Well, I take that back. Some states can have access to federal reimbursement, but Missouri does not at this time. Kansas is working on it. Quality interpreters skilled in medical terminology, that's a huge challenge. If you think about the breadth and the robust language that physicians have to communicate with their patients, we go everywhere from the emergency department to labor and delivery, inpatient psych units, which can be very challenging to interpret in, all the way down to like your infected hangnail kind of thing. So we have to really have a breadth of medical terminology. So our health literacy has to be stellar and be able to adapt to the level where our patient might be. So, if you're dealing with a 4th grade reading level of a Mixteco Indian, you have to be able to bridge that, and it can be very challenging. Then, not to mention, we have to kind of maintain files in our head for different Spanish groups, so Cuban versus Mexican versus Puerto Rican and Dominican, all very different dialectically. So the interpreters' skills have to be really, we're constantly working to improve them. Again, a moving target, we already touched on that we're constantly getting these new populations in that we're not really sure how to effectively provide communication bridges for them. It's an ongoing challenge. We're always looking for new resources, and that doesn't mean funding. That means language resources. Finding that one Chucky's interpreter that's available at 3 o'clock in the morning. We're always looking for that person. If you know them, please give us a call. You know, the other challenge is, I mean, it's a great environment to be in a teaching hospital, but it comes with barriers in that every July we've got a new harvest of new residents who frequently come green and have never worked with limited English patients, nor have they ever had to facilitate communication with a patient through someone else. That can be both difficult to, you know, to kind of deal with or learn to adapt to, and they don't necessarily get that training in med school. We have a very strong relationship with UMKC School of Medicine, and we're currently working on delivering enhanced modules to our third-year med students in clinic, and you know, working on delivering or providing them the skills that they'll need to be able to do a culturally competent history, to learn how to utilize an interpreter, to understand folk medicine a little bit better. So we're trying to do that kind of a project, and we're going to see how it goes. We'll let you know. Hopefully, maybe we'll come back next year and let you know. Overall, though, you know, one of the biggest barriers is changing culture at an organizational level, making systems more responsive to the patient and not so responsive to the physicians. So the systems at our hospital are really set up to meet the needs of the physicians, and sometimes the patients get left out of that equation, and so it's really challenging to change organizational culture and can sometimes take up to 10 years. So it's a patience challenge for those of you working in this area. And so that's essentially kind of my attempt to link language access and health literacy. I hope that I'm getting a rah-rah from Gwen in the back, that hopefully we hit on some of the things that she really wanted us to address. Should you have any questions later, or you come up with something, or if you know that Chucky's interpreter or that Mixteco, feel free to call me or email me with questions. So thank you for your attention today.
All right, thank you, panelists. Wow, this has been really interesting, and I'm sure that you all have a lot of questions. We have a few minutes for questions before lunch, so we're going to take that time now. I would, again, advise the panelists not to lean back in their chairs or slide back. It really is a tight space back here. So we are ready now to take your questions. Melinda Hemmelgarn, please. Oh, I'm sorry. My error. We're gonna make you use the microphone. Okay. Here it comes.
Okay, so I'll publicly. Is this on?
It's good.
Yeah. Okay, I will publicly say I understand why Gwen didn't let you say no. I'm curious to know. I love this story. Well, I actually hate this story about a service being mandated with no federal funding. Are you or Lisa, because I equally love the health coach idea, able to show how much money you save?
Do you want to go first? Okay.
At this current time, they have programs in place to do evaluations of our program to show overall how all the FQHCs and the emergency rooms are saving for non-emergency visits or patients taking medications improperly. So there's a program that's in place for them to evaluate. So at this current time, we don't have any information, but that is something, part of the process that we are implementing to show that this program is effective, because we are able to save the federally qualified healthcare centers this amount of money, or the emergency room, the hospital, a certain amount of money for treating non-emergency visits.
Thank you. All right, well, I have a question along those lines. What pardon?
Sorry.
Oh, you ready?
No,
Go ahead.
I think she wanted a two-part answer.
Oh, two-part?
Yeah? Okay.
Oh. Hey, this is my show. Get your own show. Yeah, no. Please, go ahead.
At Truman, we're quite fortunate to have an administration that makes that connection, that sees the value and the relevance in terms of not only doing the right thing, and providing language access, but also the preventing risk side of things. So we've had absolutely no pushback from our organization to have a dedicated department. I've never had to fight for FTEs, those kinds of things. But not specifically Truman, but there are resources available that actually do that cost-benefit analysis and do that business case kind of sales pitch that organizations that are struggling to get administrative support can utilize to demonstrate the cost effectiveness of having interpreters available. Feel free to email me. I can send you some current articles that I just reviewed probably 2 days ago that deal specifically with that cost-benefit analysis piece and looking at how affordable it is really when you do the math to have interpreters versus having suits filed against you. So,
There's a question there, or there.
Sorry. For Lisa, do you have, or is there a process in place to train other communities to develop these coaches?
Yes, we do have a health coach training program. And also to note, we have health coaches that are already located in the FQHCs, and we do a health coach training with them. So that is something that I could provide some information for you. I'll go ahead and give my phone number, my contact. Sorry, I did get opportunity to put that on the slide. But my contact number in St. Louis, it's Lisa West, and my phone number is area code 314-879-6357. That's 314-879-6357. And then my email address is lwest, L-W-E-S-T, at stlouisihn.org. That's stlouisihn.org. I'm sorry.
One more time.
Okay, sorry. My email address is lwest at stlouisihn.org. And if you give me a call, we can arrange some training on an individual basis for the program.
On your program, you'll find our website too, and we'll have information about the speakers and their contact, and even some of the slides and those kinds of things on the back too. So you have another resource for you. I think we have time for one more question, and a couple of folks had their hands up there. Okay, right behind you there.
This is addressed to the person that has the Health Literacy Depot, and I was wondering if there would be a site there that would, I don't know if you're familiar with Snoops, where you could evaluate whether, say, the popular media is credible or not. And I'm thinking in terms of Kevin Trudeau. I don't know if you're familiar with him and his quack books on Cure Yourself.
Thank you for the question. We're trying to develop an evaluation process ourselves that would be internal, so that before we put the resources up, there would be some type of perhaps good seal of approval. You see these things on eBay today in terms of people who are recognized good sellers and the like. It's still very fluid. We have not decided on how to do that, but it will be very important to be able to collect feedback from the people who actually use it. So to respond to your question, we will welcome to be able to get that kind of feedback from the people who take advantage of the resources.
Okay, very good. We are at that point where we have to balance the need for questions and the balance to have lunch and stay on time. And Dr. Edison is going to say one more thing here, but I would also point out that the Center for Health Policy has health literacy handouts in the back if you want to take some information for us. And then Dr. Edison.
Real quick, I just wanted to highlight, because it didn't really come up, one of the demo projects that Arthur had on his slide was on the other side of the state in St. Louis, was really funding a demo project around telehealth interpretation with LAMP. And we're very excited in Missouri with our telehealth network. You know, it's really being built out to a lot of community health centers and rural health clinics and critical access hospitals. And as a provider with challenge of caring for Burundian refugees and a bunch of other folks, I can tell you, for me, the value added of having, if somebody can't be there in person, at least having somebody I can talk to, because I find it very difficult on the phone personally. And so I'm really, real excited about having the value of the video to have a culturally competent, trained healthcare interpreter right there in your local clinic, no matter where you are in the state. And I hope that maybe in my lifetime anyway, we can see that eventuality for Missouri.
Yeah, very good. And we're really thrilled with all the demonstration projects that are coming forward with our health literacy project, and we hope to disseminate the information from those widely. I know that some of you still had questions, and so I would invite you to come up here after we break and talk with our speakers. Keep them there for just a few minutes, but we're all going to make our way to lunch, which is that direction through the room there. And I want to thank the panelists once again for their insightful presentations.